everyone, welcome to the special episode. I'm Shamira Biluvai. Today we are going to discuss about AV fistula. I know definitely you will be having a lot of questions, so we do have a very special guest from a renowned hospital, that is NU Hospitals. We have with us today Dr. Krishna Prasad T, senior consultant, well-known urologist and transplant surgeon as well. And definitely he have a huge work experiences in leading centers of India and UK as well. So first of all, sir, we are really honored to have you here.
Thank you.
Welcome to the show.
Thank you.
As you know, I really want to know the explanation, the real meaning of AV fistula. Can you just please explain us?
So, I once again thank all the audience which is, looking at this program. And while Shamira did introduce me as a transplant surgeon, what most people don't realize is long before a patient comes and gets a transplant done, he or she is probably on hemodialysis. And to get dialyzed, a patient requires blood to be taken from their body to the dialysis machine and returned back to the patient's body. And the device through which it is done is called an access, and this access can be man-made, where it can be in the form of a catheter, or it can be something made from the patient's own body, in which case it is called an AV fistula, which stands for an arteriovenous fistula. So that is what is needed for a dialysis patient to be on dialysis till the time that they get transplanted, and that is a very crucial part of their entire life history during the process of getting a transplant. So it's an extremely important surgery to have done at the right time and at the right place for you to be adequately dialyzed before you get a transplant.
Doctor, can an AV fistula be used for emergency dialysis, or else what are the other options are there?
That's a very good question, and while I have already told you that an AV fistula is the lifeline for a patient who is on hemodialysis, it cannot be used immediately for starting hemodialysis. It takes time for a fistula to mature, and after which only it can be used. So the answer to the first part of the question is usually no. Majority of the fistulas cannot be used for emergency hemodialysis. So what are the other options a patient has when he comes for hemodialysis? So this is predominantly what we call as catheters. They are tubes which are placed into the patient's neck or the leg, into the big blood vessels of the neck or the leg, from which we can take out blood, send it to the dialysis machine and purify the blood and push it back into the patient's body. So a majority of times emergency dialysis is started on what we call as catheters.
Doctor, actually what is IJC and how it will help for the CKD patients?
So this is basically an extension of the previous question. An IJC, so you have usually used the commonest short form, which is used by most medical people or doctors, and maybe more experienced patients will also start using the term. It stands for internal jugular catheter. So the internal jugular is a large vein which is present in all our necks, and the word catheter obviously stands for a tube which is inserted into the neck. So an internal jugular catheter is a form of a catheter which is placed in the neck for starting hemodialysis, usually the emergency hemodialysis. And how is it going to help a patient with chronic kidney disease? So the word, again, what one must understand is chronic kidney disease, and that's where I want to educate all our patients. Well and long before you are started on dialysis, most patients are aware that there is some problem with their kidneys. It is a small percentage who land up in our emergencies without having ever known that they had kidney related problems. And that is where I want to tell all the patients who are listening to this, if you are a patient with chronic kidney disease, try not to get on to hemodialysis using an IJC or a catheter. Try getting on to hemodialysis using a fistula. So that is my message to all patients with chronic kidney disease.
Doctor, how long it can be used for dialysis actually?
So when we talk of the IJC catheter, it's usually the temporary catheter which is always referred to as the IJC. And this temporary catheter can be usually kept for a period of up to 1 month, maybe stretched to 2 months. But ideally by the end of a month you should be planning whether you want to get a fistula created, which you ideally the patient should have had created many months before, except in this case where he has come in an emergency, or you must plan to go on to what we call as a permanent catheter. Though the word used is a permanent catheter, it's usually what we call as a slightly longer lasting catheter than a IJC, and that is something which patients can use, and that lasts for up to even 1 year, sometimes even 2 years before they can be removed and replaced. Temporary catheter, like I said, is preferably to be kept only for up to a month.
Okay. Doctor, can you please brief about AV fistula surgery to our audience?
So moving on to AV fistula surgery. So again I said it is arteriovenous fistula. So the term has two pieces to it. Artery, which all of us are aware is the blood vessel which brings blood from the heart. So in layman's terms, let us say good blood. And the vein, which takes back blood from all your hands, legs, maybe your head and neck, your stomach. All of this impure blood in layman's language is going back to the heart. So that is the vein. So in an arteriovenous fistula, what a vascular surgeon like me does is joins the vein to the artery. And why are we doing this? If you look at your hands, just look at the upper side of your hand, you will find multiple blue colored veins which are there on your hand, and these are the veins which I am talking about. They are small in size, they have very little blood flow through them, and the pressure is very less. But if you try to feel the pulse on both your hands or even your neck, and why is there a pulse? The pulse is there because the blood which comes from the artery is coming at a very high pressure. So the advantage of an artery is the blood is under high pressure, the blood comes with a good flow, but I cannot puncture arteries. Every hand has maybe 1 or 2 arteries, and if they are blocked, you will have gangrene of your hand and you will not be able to use your hand. But we have many veins. If you look at the top of your wrist, you will find that there are many veins. So we use these veins which are good to see and very superficial, we join them to the artery. And because of this, we can call it short circuit. The veins start developing a much higher flow, and since they are softer, they become larger, and the pressure inside them increases. And to these veins, we can put in 2 needles from which we can take blood out, send it to the machine, purify the blood in the dialysis machine, and bring it back to the vein. And we can puncture these veins again and again and again without having the risk of puncturing the artery. The artery which had the high pressure and the high flow cannot be punctured. Now by making the short circuit, I now have a very easily visible vein which has high flow and high pressure, which I can repeatedly puncture and be used for dialysis. So that is what a AV fistula surgery is. And where can we do it? Anywhere where I can find a good artery and a good vein. It can, most of the times, 90% to 98% of the times, it is in the upper limbs, right or the left upper limb, depending on whether you are right-handed or left-handed. Rarely and very rarely in the lower legs. Okay.
Doctor, I have a small doubt. Now, when can a dialysis therapist start dialysis through AV fistula?
So, like we discussed earlier in this part of the program, where some fistulas you may be able to start dialysis quite immediately, especially if it is being used and then I repair it and I reuse it. So in those fistulas which are already in use, you can do it on the same
Yeah.
day. I have patients in whom we have operated on an emergency basis and used an old fistula within a few hours of surgery. But for someone who is getting a fistula done for the very first time, it takes up to 4 weeks for the fistula to mature, sometimes an upper limit of 6 weeks before we can say the fistula is mature after we do some scans, and at that point it can be used for dialysis.
How this surgery will help those patients who are suffering from chronic renal failure, doctor?
So that is the most important point I want all patients who know that they have chronic kidney disease to understand. You know, or your physician or your family doctor has told you that you have kidney failure. Please ask them, what is the right time for me to get a fistula created? I am sure they have already told you that you have to be under the care of a nephrologist, and then there are certain points in your disease process, if you want to say it that way, to get a fistula created. So usually by the time your kidney function deteriorates and says filtering only maybe about 30 ml of blood per minute, that which your nephrologist will be able to tell you is when you should get your fistula done. There is no way I can tell you how quickly you will require dialysis, but at least we can say that confidently that maybe you may not require it for the next 6 months or a year, and that is the lead time before which you must make a fistula and keep it ready. Because for a vascular surgeon like me, if it's a straightforward fistula with good vessels, you have preserved these vessels all the rest of your life and not used them, then in the very first attempt I can get a working fistula. But there are some patients who have gone to so many other doctors or probably even hospitals where they have not been told that you have to preserve your veins on your non-dominant hand. So if you're right-handed, then on your left hand. If you're left-handed, then on your right hand. If you don't preserve these veins, you constantly take blood from them, then these veins are lost. I will not be able to make a fistula on that hand. So they will come to me with both veins in both hands completely damaged, and I cannot use them for creating a fistula. So what you need to understand is, if you know that you have chronic kidney disease, preserve the veins on one of your limbs, whichever is your non-dominant limb, and do not get IV medications put in them. You can take insulin, there is no problem. They can measure BP, not an issue, but try not to take intravenous medications. Anything which needs to be injected into the vein needs to be avoided. Otherwise, a vascular surgeon like me will not be able to help you to get a working fistula at all. So that is what you need to remember. And the second most important thing is, which you need to remember, if you have chronic kidney disease and you come and need emergency dialysis, it is far more safer to get it done through a fistula than through a catheter. Because like I told you, catheters are short term and they have problems. They are more prone to infections. And it has been studied and researched, and even in Indian patients it is well known that every single admission for infection with a catheter, you will spend close to about $1.5 lakh in a hospital, probably in any hospital. So if you have say 2 or 3 infections, you will probably be finishing the cost or expending the cost of a transplant before even getting there. So that is exactly why you need a fistula. 1, you don't want to have repeated infections, and 2, you want to always start dialysis on a fistula and preserve all the veins of your neck and hands, so that in the future, if at all your fistula stop working, we may have access to it then. You shouldn't be starting dialysis on a catheter.
So doctor, what will be the lifespan of an AV fistula?
That's a very good question, and there are many layers to this question. And it depends on the patient, it depends on where you are getting dialysis done, and it depends on who is your vascular surgeon. So I think all these 3 components play an important role. Let's start the circuit from the patient, who is the most important part in this whole story. when you make a fistula and when somebody has created a fistula for you, remember it is something which is there in your body. You have to take care of it. So how do we take care of a fistula? You make sure that you do not have any injuries on that hand, because sometimes you can have fistulas which having a blood flow rate of nearly 1.5 liters a minute. So think of 1 liter bottle of water being filled with blood every minute. So you have 5 liters of blood in your body, and if you injure that hand and if your fistula ruptures, then you're leaking blood, and you're leaking blood at the rate of 1 liter a minute. So it doesn't take long for some things to go wrong. So you need to take care of the fistula, avoid any damage to the hand or injuries to the hand. When you go to the dialysis center, wash your hands before they put needles. It's a very simple step. Across the world now, in medical literature, it has now become very clear you don't require fancy soaps, you don't require fancy hand cleansing agents, you just need to wash your hands. Just washing your hands reduces infection rates by over 95%. So just washing your fistula hand before the technician puts in the needles reduces your rate of infection significantly. And then it is your fistula. The dialysis technician is going to change every few hours, probably because they have many rotas or many sessions to attend to. So insist that the needles must be put to a different location every time. If they are not put at different locations every time and you are injuring the same part of the fistula, that part can rupture at a later date. So the patient must take care of this. And then when the dialysis is closed, a lot of hospitals put in very tight bandages to prevent blood from leaking. It is the responsibility of the patient for you to remove these tight dressings, or tell the technician that these dressings are too tight, and notice whether bleeding is occurring for a long time. If bleeding is occurring from a long time from your fistula after they remove the needles, then you need to meet your vascular surgeon. There's something going wrong with your fistula. So this is what a patient must do. And the technicians obviously are trained by us. And believe me, this is a problem worldwide. I have traveled to the US, the UK, to Singapore looking at vascular access, and however much we educate technicians, they are on a busy schedule. They try to needle the same place because it's very easy to get blood, and so they just want to be done with that 3 or 4 sessions of dialysis. So technicians, whoever sees these programs, if you are a technician, if you know of someone in your family who's a dialysis technician, you need to change the places where you put the needles. So unless you change that on a regular basis, you are yourself going to cause a fistula rupture at some point. And lastly, vascular surgeons like me or access surgeons like me think it is our responsibility not to just join 2 blood vessels together and hope that it works. You need to ensure that the patient has a working fistula which can be used for dialysis. I have seen from a lot of peripheral hospitals, and not just here, again all over the world where I have traveled, where surgeons have just joined 2 small vessels, knowing very well that this may not be able to give a usable fistula for this patient. So they need to think as to what they're doing, and whether this is going to be useful for the patient. You need a dialyzable fistula. You just don't need a connection between an artery and vein. So that's where the long years of experience and learning these things from many centers across the world and trying to bring them to our Indian patients is what I think makes NU and at least a vascular access surgeon like me unique, that we are trying to bring this I think we can say the best parts of worldwide care to the Indian patients.
Doctor, this is just out of a curiosity I want to ask you. Is there any failure in this for this surgery?
So like any surgery, I mean, I would like to again tell this to all patients, not just chronic kidney disease patients. We are surgeons, we are not magicians. There is failure rate, and in fistulas, if you are in a center which does very few fistulas, it has been shown that you can have up to 50% failure rates. That means every other surgery you do can fail. and if you say are getting it done by a vascular surgeon who has a very good experience. So in my own hospital, I have worked out my failure rates, and they are 8%. So I have about a 92% success rate in creating fistulas. But you do have to understand that even in my hands, I have an 8% failure rate, and this could be majority of the times because of factors which I cannot control, and that is why I managed to bring it down from 50 to 92, which is a success rate. But so there are many factors which may not be under my control, and these probably will lead to failures anyway.
Okay. Doctor, can you tell us about the fistula rupture?
So we have discussed this in bits in the answers to few of the previous questions. And why does a fistula rupture? So two very common reasons why a fistula ruptures. One is infection, and the second is poor needling technique. So, and each of them are interconnected. If you don't wash your hand before your technician puts a needle into your fistula, then it is bound to get infected at some point of time. And when this infection sits inside the blood vessels, the bacteria continue to live there. They weaken the wall of the blood vessel, which is the vein, and ultimately it will rupture. So that is one part. The second and the most commoner thing which we see, like I said, everywhere in the world, is technicians insisting on putting the needles at the same 2 points every time. And patients are also very, I just want to emphasize this to the patients. I understand that for someone who is on chronic kidney disease, hemodialysis, it is very convenient for you to get the same technician to put the same needle at the same place 3 times a week and get dialyzed, and you are safe that your dialysis is finished within the set time without any problems. But doing this again and again and again damages the skin and the blood vessel under that fistula there. And our body can only heal so much. After a particular point, the skin and the vein over that region becomes extremely thin. So it's just like a stretched out balloon. So the next time you have a very thin stretched out balloon and your child comes to you and you touch it even with a pencil or maybe even with your fingernail, it can rupture and the balloon bursts. That's exactly what happens to a fistula which has been weakened over time by repeated needling in the same site again and again and again and again. It becomes so thin that now even you have patients who come and tell us that I was in the washroom, I just washed myself, I gave myself a soap bath, I rubbed it a little harder that day and my fistula burst. Or I will have majority of the times patients being referred from dialysis centers saying, today we tried putting in a needle and the bleeding has not stopped at all after we removed the needle, because now there is no more skin left, no more tissue left there to heal and close the fistula anymore. So that is a fistula rupture. And like I already told you, sometimes and majority of the times actually, fistulas can be having a blood flow rate of almost 1.5 liters. If they are fistulas made in the leg, you can have flow rates of even up to 3 liters a minute. So I don't have to tell you what happens if something like that is open. So 3 liters in a minute, in less than 1.5 minutes, you can lose all the blood in your body. So that is a fistula rupture. It is an emergency. You cannot be sitting at home when your fistula ruptures. You need to come to the hospital.
Can we consider this as an emergency medical situation, and how do you treat this?
So this is a life-threatening condition. In fact, in the West, it is a known cause of death. 0.001% of patients in the Western world die because the fistula ruptures at home when there is no one around, and these people are found dead at home after having bled completely all the 5 liters of blood. So this is not a situation we want. Luckily, at least in India, we still have the concept of a joint family. I understand it is gradually going away, but we all have someone at home. So if your fistula ruptures, The first thing you need to do is put pressure on that hole which has formed there. I understand that the blood flow is extremely high, it is very frightening for patients, but the first thing you need to do is close that hole with a finger. If you have anything at home, it can be a towel, it can be a hairband, it can be anything which is like a rope. Tie it above the fistula so that there's no more blood flow to the fistula, and then put your hand on the fistula where there's a hole, and the first thing you need to do is rush to a vascular surgeon who is capable of dealing with these things. So that is a life-threatening emergency which should not be neglected.
Okay. Doctor, definitely prevention is very much important. So how can a patient prevent this?
So we discussed this under two headings earlier. One is infections and one is needling techniques. So taking care of your skin, especially the skin where the fistula is, it might be in your upper arm, it can be in your leg, is very crucial. You need to wash your hand and leg wherever the fistula is daily. Use ordinary water. A lot of patients of mine says, can we use hot water, can we use cold water? Any water is fine. I don't have any specification of what soap you want to use. You want to use Dettol, you're welcome to use Dettol. You're welcome to use any soap. So any soap, any water to be washed at least twice a day, and dabbed dry, and keep it clean. And when you go to your dialysis center, ensure that you have had a bath that day. If for whatever reason you're working, I've had patients who are on night shifts who come directly from the factory to the dialysis center, so they may not have had an opportunity to have a bath. Most of our hospitals have an area which you can at least wash your hands, go to the washroom, wash your hand which has the fistula, and then go to the dialysis room. So that will avoid infections. And then insist, it is your fistula, ownership has to come from the patient. So I would insist that you tell your technicians not to put the needles at the same spot every time. Change the needling site. And lastly, if you think that the fistula is bleeding more than usual when you remove the needles, then please meet your vascular surgeon to see what is going wrong. And most importantly, please meet your vascular surgeon or an access surgeon once every 3 months so that they can see what is happening to your fistula. There might be so many things which you as a patient perceive and understand over a period of time because you have chronic kidney disease. But as more experienced vascular surgeons, we will be able to tell you whether this is an impending fistula which is going to rupture and that it needs emergency attention.
Doctor, actually we would like to hear from you any of your patient's case study or a story who has had a very complex dialysis history. Can you please share?
So there's one story which sticks to my mind because I have been treating this patient for the last decade now. She's well into her 60s, and she's from a ordinary middle class family with 2 children, taking care of them. She's a homemaker, and she had seen me about a decade ago. At that point of time, she first went through the same phase of denial, anger, acceptance of chronic kidney disease, and I remember making her fistula for her on her left hand first, which she used for a couple of years. When that failed, we made a fistula higher up because we were not able to save this fistula for her, and we made a second fistula on the same hand higher up. So she used that for about another 2.5 years. So that brings it up to about 4.5, 5 years. Once she used that fistula for a couple of years, any fistula, if you don't take care of it, starts developing narrowing in the big blood vessels of the neck. So she ended up having narrowing in the big blood vessels of her neck. We had to put stents in there so that the blood flow is maintained and the fistula stays open. After some time, that stent closed down, just like you hear about stents in the hearts getting blocked, just like that this stent got blocked. And then after that, we made a fistula on her right hand, and quite immediately after making that fistula, she started having swelling on her face. So that prompted me to have a look and say, well, she had narrowing on the right hand, right big blood vessels of her neck. Was something going on similarly on the right side? And because she's had a few catheters placed on the right side, because between the fistulas waiting for one to develop, we have a little time span of about a month and a half. So she had a few catheters placed on the right side. When we looked at all the big blood vessels in her neck, we found that the blood vessels here were closed. So I said this fistula is going to be unusable because the main road is closed. All the blood is coming from her heart, but instead of going back, it's getting stocked here. So she started developing swelling of her face. So I distinctly remember she has gone to every single vascular surgeon in Bangalore before coming to me, and the opinion which they all gave to her was that we really cannot do much with that fistula right now.
Okay.
So I think after discussion with the family, I suggested to them that they could, along with my nephrologist, we suggested that she can try peritoneal dialysis, which is a different kind of dialysis, much more softer, much more easier for the patient to stay at home and do. So for the next, I think, 2.5 years, she was on peritoneal dialysis. So that's about 7.5 years now. And unfortunately, she developed infections of the peritoneal catheter. And we were not able to save that catheter, so we removed it. And then she again decided that she wanted a fistula. At that point of time, there was no more place in the upper hands to do a fistula, because both the blood vessels, what we call as the main roads, are closed. So I can't make a fistula in the hand. So I made a fistula for her in a leg.
Okay.
So we call it an AV graft. Even if you go across the world and ask many vascular surgeons, they probably have about 7 to 10 patients. They pretty much any vascular surgeon across the world, when I ask them how many patients do you have made a fistula in the leg, that was about 3 years ago now. So she's now on the 10th year of her dialysis. I have created 3 fistulas, peritoneal dialysis, now again fistula in the leg. This fistula I have repaired twice to keep it going. Just I think in June of 2022, just this month, May, June, I repaired the fistula for a second time to give her some more time on this fistula. So she's now a decade into dialysis, and she carries on. She comes home. She does come to the hospital every time, and she says, I have pain sometimes when I'm making chapati for the family. So she's an active homemaker even now, running 10 years into dialysis. She's one of my special patients whom I have a soft corner for. So hopefully, I hope someday that she gets a kidney. Till then, I will have to, stretch her dialysis sessions by making all these efforts.
Really, doctor, while listening to your case study, I believe that a huge round of applause for your whole work, your experience, everything matters here. So finally, is there any suggestions or advice or awareness message to our audience and the patients?
If I have to, insist or stress on one point for any person who knows that they have begun their journey in chronic kidney disease, please talk to your nephrologist, find out when is the appropriate time to get a fistula surgery done, and please get it done. Don't postpone it till a point that you require emergency hemodialysis, and then you will end up staying on a catheter. You will end up causing problems in all the big blood vessels of your neck, which may ultimately hinder even the creation of an AV fistula. So if I have to stress on one topic or one aspect of chronic kidney disease management, then it is about getting a proper AV access or an AV fistula access. We have a saying among all us access surgeons that a patient who is a chronic kidney disease patient requires the right access at the right point of the time or at the right point of his lifetime, based on his or her needs and work which they are performing. So it may not be that what fistula your colleague or someone else whom you found out about is having should be the right fistula for you. Someone who is 80 years old may probably be more safely managed and more humanely managed with a catheter, rather than subjecting him or her to the repeated abuse of needling the patient every time at that age, especially someone who may not have a much time left to spend with his near and dear ones, would probably be happier staying on a catheter, whereas someone who has many years of productive life left should probably always look for options of getting an AV fistula, taking care of it, and so that it can give you a reasonably long usage by the time you get someone to donate a kidney to you, so that you get on to the transplanted side of life, I would want to put it that way, and keep that fistula, because we all understand that. I always like to tell my transplant patients, a transplant is maybe a 20-year treatment at the best. Maybe it may be a 5-year treatment for you if it fails early, but it's a 20-year treatment. At the end of those 15 or 20 years or even 8 years, when you require hemodialysis again, your best friend is your fistula, not your catheter. So that is the message I want to drive across today to all patients with chronic kidney disease. For please protect your veins of your non-dominant hand and try to get a timely fistula, so that it saves you a lot of trouble, not only just financial, but probably even in terms of health, and both mental and physical will keep you safe in the long run.
Okay, doctor. Doctor, it was really nice talking to you, and thank you so much for the time. Thank you so much for joining us.
It's a pleasure. Thank you so much.
As you all know, health is wealth. So please take care of your health. Take care. Bye-bye.